Hello, good evening, everyone. So we will start this session. I hope everybody, I request everyone to settle down, please. Oh, yeah, yeah. Okay, so we are all set. A very good evening to everyone. I'm Dr. Valerie, and I'm the State Nodal Officer for State Health Systems Resource Center, Meghalaya. And I would like to welcome each and every one of you, our distinguished panelists, our guests who are here, participants. I'm very happy that you could make it to this session today. Being a last session of the day, I'm very glad that you could make it. As you've seen, we have distributed some handouts to you. This session today, we expect it to be a bit different, not a one-way conversation, but we would like it to be a little bit more interactive. Okay, so to start with, it is with great privilege and honor that I welcome to the dais Dr. Sampat Kumar, IAS Principal Secretary to the Government of Meghalaya for the Department of Health and Family Welfare, etc. I would also like to welcome to the dais Shama Shri Das. She is a Senior Program Officer for Strengthening Institutional Capacity in the health team of the Gates Foundation India office, where she leads investments that engage government, academic, and research institutions to strengthen health systems and accelerate adoption of scalable technology. Before we go ahead, I would just like to give a brief insight on a bit of what we want to do here. So as of now, we are meeting at a time when healthcare across the world is undergoing a very profound transformation. And there's a rapid advance in technology, growing health needs, and collective aspiration of quality service as well as equitable services in health. With this context in mind, digital tools are no longer an option for us, but it is something that we should leverage in order to advance the needs and aspirations we have for the health of our people. So we have electronic health records. We also have telemedicine, which we are already doing. Apart from that, real-time surveillance and AI-supported clinical decision-making. This is how we aspire to deliver services, train health workers, manage data, and respond to health emergencies. However, technology alone cannot transform health systems. The real strength lies in the people who are confident, competent, and ethically grounded in using these tools, from the community and primary care providers to specialists, program managers, and policy makers. This panel brings together valuable experience and diverse perspectives, and I'm confident that today's discussion will help us explore new pathways and practical pathways to address the challenges that we have in the health system today. With these words, may I begin with Sri Sampat Kumar sir to give a bit of context on the work that is being proposed in Meghalaya. Thank you.
So, good morning to all of you. Nice to see everyone. A lot of people who are here in this room, I know most of them. Thank you for attending this, session, and thanks to Shama from Gates Foundation, and also the Dr. Adapa Karthik, who's from the WHO. He's my colleague in the IAS, and Amnesty, Professor Amnesty from John Hopkins, and Professor Divakar from again John Hopkins, and on all my team members like Dr. Valerie and SSRCT. So what I would like to share here about the why it is so important to build the AI readiness and digital competency among frontline workers. So I think while most of the healthcare, if you ask me, it's delivered by the frontline. And why it is delivered by frontline, you can see in the pictures. You have seen how actually the kind of frontline workers are trying to really solve problems at the last mile, delivery issues. So while especially this is all the more important for especially states like Meghalaya, underserved or hard to reach areas, where it is the frontline workers who are actually closer to the problem. So it is important for us to really build that capacity, or the state capacity at the front line. So what government of Meghalaya is trying to do is that how actually we can really build the state capacity or state capability, we call it. Building state capability is one of our prime objective. To do that, we started actually looking at by seeing the context, how do you really empower it. So when we started this work, this was the problem. Just I wanted to share this problem with you. In fact, by seeing this data, what you can see is that our maternal mortality rate is almost like 3 times than the national average. So again, what is the reason? You go and see the difficult challenges. 25% of the villages are hard to reach villages, and it's so difficult for any pregnant mother to come and on time to really get a safe delivery. So this is again, when we looked at these are about the data. But what was happening was that when we were not thinking about the building state capacity, the usual default approach was that we have massive national programs, massive we have, but the focus was more on implementing the programs, rather than solving the problems. It's a kind of a kind of a default explanations used to come. Why MMR is very high? Because we have less specialists, we don't have infrastructure. These are the kind of general answers, and people used to think that this has to be fixed by some central authority, not by them. Not by them means those who are closer to the problem. So how do you shift? Shifting that identity of frontline workers was the important shift that what we made in terms of building state capacity. How do you shift the identity in such a way that where there is a sense of purpose. They people look at that they can actually innovate, they can solve the problems instead of looking at always something from above. Then the second important thing what we have observed was, we used to collect a lot of data. Data was there, but we are not analyzing the data. In fact, this I spoke yesterday also in another conference with the Secretary Health, ma'am. So we were collecting, but we are not actually using the data. We are not analyzing the data. We are not actually make sense of the data. So how do you effectively use the data? So these are the two problems that we try to fix. In that sense, actually, and once you actually empower, in fact, data is a motivation. Data really can provide positive public service motivation if you really use it in a right way. So that is something that, if somebody knows that, I'm actually saving lives because of this data. In fact, it's much more, it's a basically sense of purpose. How do you build it? So we created this, framework in 2020, and we started actually implementing this work in the state of Meghalaya. Just broadly, we call it building, state capability. How actually, especially the main purpose is how do you restore the purpose? How do you restore the purpose, to solve problems, which are, in the locally contextual manner. So as part of that, one of our main pillar is that building the front line, building the leadership at front line, building that decentralized leadership at the front line. And then, of course, there's another thing, how you're able to use the data and research. And of course, we are inspired by some of these theories that I would like to, I think most of you are aware, but just one of the important theories that adaptive leadership, giving work back to the people. Those actually, it's a phenomenally empowering. If somebody comes that I have a problem, if you ask them, give the work back to them, solve the problem by yourself. It's like giving agency. So this is what was happening in the state of Meghalaya. And then how do you, then of course with a purpose that, state has the capacity. It's like a mission economy, like state has the capacity to bring transformative development, because it is the people, state means what people. So that's where we are working, and this is the framework with which actually we have been working, and we are getting some good results. In fact, that's where we are able to, share some of this work. And today, I think Shama will take the next slides, how actually we are introducing this entire, framework, especially how do you bring this AI readiness and digital competency framework within the system, Shama. Thank you.
Good evening, everyone. Great to see a full house at 6 in the evening, so thank you for being here. Thank you, Dr. Valerie, for the kind introduction, and to Sampath sir for setting the stage. We signed an MOU with the government of Meghalaya, which is centered around health. And to be very honest, while digital health was a component of the Memorandum of Understanding, we weren't really thinking AI, but like in a year and a half, AI is center stage. And that's what happens with technology. So in the next couple of minutes, I'll try to just further the case of why we need competency as a core tenet of newer age AI tools. And I scanned the summit. I don't think there are any sessions apart from this on competency. So that, I think, is a relatively uncharted territory in this field. So like any other technological innovations, whether it was internet, whether it was mobile phones, and today it's very difficult to imagine that both of them were different inventions because they are so closely interlinked today. But with any innovation, you will have naysayers, and fortunately or unfortunately, we are introducing AI-enabled tools in the age of digital and super connectivity and disinformation. So it's even more important to understand what competencies would be needed in the ecosystem that the tools are introduced. So this slide is very Meghalaya-centric. So the words that are mentioned on these slides, most of you might not be even familiar with. And Dr. Marba will talk about village health councils, ASHAs and ANMs, pretty much everyone knows. But what an ASHA app does in Meghalaya is very Meghalaya-specific. What the mother app does in Meghalaya is very like ANM and maternal and child mortality specific. But the point is that all of these tools today have some features. So the ones you see in brown are features which already exist. So I'll take the example of, say, the ASHA app. It's for incentive management. But we know that it's just a matter of time that newer features will come in. So features of like decision support, stock management, referral support, it's not too far in the future. It will come. But are we designing it keeping the health worker at the center? And the health worker is not one person. It's a heterogeneous group. You pick up states, the state's frontline workers are heterogeneous. You pick up a cadre, within that, every cadre operates differently. And so how the AI-enabled digital tool will be rolled out needs to think of that. And that's why the competency of the cadre of that specific individual needs to be mapped, needs to be measured, and like the session says, it needs to be built over time. If you think of MS Excel. I mean, I don't know how many people use Microsoft PowerPoint now because now Canva is there. How many people use, even the iPhone, right? People use less than 5% of what the tool can actually do. So when we are introducing AI tools with such large investments, are we even unlocking the full potential of the tool? And that can actually happen if you enable ASHAs, ANMs, village health councils, any cadre that you talk of, do an analysis of what are the competencies you require to unlock this, what are the competencies you today have, and what is the journey you need to make. So that's like the big thing. The second is, like Sampath sir was saying, frontline workers are the closest to the community. It's not about deploying a fancy tool. It is about providing universal, affordable care to patients. And they know the community best. So if you are not enabling them to use the tool better, it is a disservice to them and to the community. And the third, which I think you will hear in pretty much every room that you entered in these 5 days, is about safety. It's about trust. You have to think of those things. And today I don't think the frontline workers of this country, especially in some settings, are ready for it. And so we'll delve deeper into these competencies and where AI fits into the picture. Okay? So can I move it to Dr. Valerie, and then she can move it forward. Thank you.
Thank you, Shama, and thank you, sir, for putting the perspective of Meghalaya, the geographical challenges, and the various other challenges that are there. But we hope that with the enabling environment that is there, we will surely, overcome these challenges, and we would go ahead in terms of improving of our health indicators. And I'm sure that with the support of Gates Foundation, Shama has, I should say, hit the nail on the head, right? When she said about the competencies and of health workers and how we use the AI tools, not only AI tool, any digital tool, in fact, for the purposes that we think it is being done, but then actually because of it's not it's underused, and because it is not as per their competencies, the usage of such tools are very very low. So thank you for that. And for our next discussion, may I call on the dais Dr. Amnesty. Dr. Amnesty is an associate professor in the University of Cape Town, and yes. Next, I would also like to invite Dr. Nayanjit. Dr. Nayanjit, he is the senior consultant for human resources for health in the SHSRC. I would also like to invite Dr. Karthik Adappa. He serves as the regional advisor for the digital health at WHO Southeast Asia region. And last but not the least, may I invite Dr. Marba, who is the senior consultant for social mobilization and gender for SHSRC in Meghalaya. So I hand over the rest of the proceeding to Dr. Amnesty, on the discussion. Yeah.
Thank you so much, everyone. So we've been cut for a little bit of time, so bear with me. I'm going to cut through some of our slides a little bit quickly. Can I just get a show of hands? How many of you have heard of digital competency before? Okay, we have some familiarity. Okay, so that means this part will go very quickly. So, and maybe just digital literacy versus digital competency. Do we know the distinction? No. Okay, one person in the back. A handful of our dear colleagues over there do. So this, again, hopefully will be quite quick. But I'm going to kick us off before I get into sort of key terminology. This next session is going to have 4 main messages. The first is that we want to sort of situate digital competency within a larger measurement process. So not only is digital competency nested within a broader process of competency mapping, we want to sort of understand it as the starting point for assessing further improvements of digital innovations, particularly as Shama and Dr. Valerie mentioned, around enhancements of existing solutions, capacity building initiatives, et cetera. You might have seen a lot of different alternatives, ways of thinking about digital competency. There are a number of frameworks on the market. I think the salient point is that they must be measurable and contextually relevant. And translating these frameworks to practical tools is an iterative and lengthy process, but one well worth undertaking. And then I think Shama made this point very nicely. We need to design solutions for where we want health workers to be, not necessarily where they are right now. So part of the sort of design of digital competency measurement, you'll see, involves a reimagining of workflows and going beyond where current digital solutions are in use and trying to recenter solutions to be around the health workers' full scope of work and away from siloed initiatives. And then finally, in sort of layering in the village health committees and including communities, we need to really sort of strengthen the state-citizen relationship and improve the connection between communities and health systems. So I led with this. I think you know it already, but just to sort of contextualize, we don't want to go through an hour of discussions, then at the end people are like, oh, what is digital competency? I thought it was something different. So these terms, digital literacy and digital competency, are often sort of used interchangeably. Digital literacy is really about knowledge and understanding of digital technologies. There's a definition on the screen from UNESCO. But in essence, it's juxtaposed against digital competency, which is really about applying digital skills in real life. The European Commission defines that as the confident, critical, and responsible use of technology for a range of purposes, including learning, work, participation in society. So it's a broader process of application. So digital competency, importantly, includes three pieces: knowledge, skills, and attitudes. Very helpfully, WHO has given us this sort of pyramid of key audiences that we need to think about when we talk about digital competency, starting at the base, population, people, and patients, and moving up, practitioners and providers, planners, researchers, developers, and then finally at the top, policymakers and decision makers. For the sake of today's conversation, we're just going to go through the base of the pyramid, just sort of noting our colleagues from the World Bank have done some very interesting work to address digital competency on the top two. So if you're interested in that, talk to Matt after. But just in terms of starting at the base, I want to sort of introduce something called the DigComp framework. This is probably the most recognized global framework on digital competency measurement. It emerged first in 2013, and the latest iteration was published last month. It gives us a sort of helpful grounding of digital competency within 5 domains. I won't go through each of these, but just simply to say that within each domain, you have competency areas. The number of those, again, varies based on the domain. And within each of these, you have a number of different digital skills, attitudes, and knowledges which can be measured. For someone to have basic digital competency, I need to be able to perform at least one skill in each of these 5 areas. In terms of population level measurement, the ITU has given us sort of this digital skills indicator, and full disclosure, we've helped them develop the questions for this. And it provides sort of a helpful foundation and a standardized approach across their 196 member states for measuring digital competency at a population level. That said, it has a lot of notable limitations. Many of the parameters are very computer-centric, it continues to be quite Eurocentric, and not well suited for mobile-first populations. In recognition of that, we've tried to develop alternative measures, including a digital access and use index, which considers the broader range of access and use considerations which are more relevant for populations like we have here in India. And digital competency feeds into that as well. So this is sort of one population level resource. And so with that kind of background in mind, I want to turn us over to thinking about practitioners and providers and ask my colleague, Dr. Nayanjit, to come up and start us off on that conversation. And I'll go there. Oh. Sorry, I realized I have one more slide. Bear with me, I'm so sorry. Okay, all right, sorry. Just sort of one more, no, please come sit. So I realized, so when we're thinking about how we're actually going to do an applied approach of digital competency measurement for Meghalaya, we're sort of thinking of it in the context of a 4-step process. It starts with tool development, moves on to the implementation of that tool, and then proceeds with analysis and use. This is not rocket science. But I just want to underscore that underpinning this process is a very lengthy, detailed process to get us to robust data that we can use to inform action. So we'll go through this throughout the slides to come, but in essence, we're going to start with kind of the tool development process, and my colleagues, Dr. Marba and Dr. Nayanjit, are going to take us through what we're doing in Meghalaya to kick this off. Over to you, sorry.
Thank you, Dr. Amnesty, and good evening to everyone. It's quite an opportunity for us to present a very humble work that we have been doing. First of all, we had to reimagine the plight of a healthcare provider within the public sector health facilities, be it from the health and wellness centers or the primary health centers or district hospital. So we were trying to map about 4 different cadres, the ANMs, the MLHPs, the staff nurses across different hospitals and facilities, and also the medical officers in different roles. Now, so being a medical graduate myself, we remember we learned what our professors taught us, and we were certified as graduates of medicine based on the expected outcomes that our professors and examiners deemed appropriate for us. But whether I was capable of actually seeing a patient after I got my certificate was a very scary situation. So we had to really sit together and understand what is it that a healthcare provider in these grassroots, where we have so much of resource constraints, deserve to be trained on. And then, the government of India's Mission Karmayogi came into our rescue. So if you all have looked at the website of Mission Karmayogi, the Capacity Building Commission, it talks about shifting the paradigm from rule-based to role-based competencies. And it talks about 3 major components in terms of competencies. Number 1 is domain-specific. Number 2 is functional or technical. And number 3 is behavioral. So it's something like this, like in towing the lines of Dr. Amnesty. So if you know how to drive a car, yeah, and you have learned how to drive a car in Delhi, you may not be able to actually drive in Ahmedabad. Okay, those who have gone to Ahmedabad, you know what I mean. And then if you land up in New York, it's altogether different because this is the other side of the road, right? So competency is outcome driven in a given context. So our medical training, our nursing training, all our healthcare training, our public health training needs to be contextualized within the given role that the provider actually plays. So looking at that, we did multiple consultations across several districts, and almost everywhere we found similar insights. So this is one of the pictures in one of the districts where we were meeting a number of stakeholders from the grassroots to the top district decision maker. And then we met across a series of consultations with experts from various domains, and we sort of did a very interesting exercise. We sort of simulated kind of a workflow that a particular patient in a health facility encounters across the experience that he or she has. For example, let's say here I'm showing the example of a woman in 3rd stage of labor in the health and wellness center. So what kind of situations does she undergo, and what kind of interactions and encounters happen? We sort of mapped this entire simulated workflow. And then we tried to understand what are the domain specific, what are the functional, technical, and behavioral competencies that the ANM must demonstrate during this entire series of encounters. And then we also extracted some of the digital competencies. So as you see, for every such process where a certain output is involved, a digital competency is not an option, as Dr. Valerie was alluding to in the beginning. It is integral part of the performance of the ANM. So therefore, just from absolutely the first encounter where an ANM meets a woman on 3rd stage of labor, she not only has to be able to clinically equipped to assess the vitals, but also use the gadgets and the devices and record them, right? So similarly, if you go to managing, let's say, postpartum hemorrhage, whether she's able to provide the right sort of uterotonics to, at the end, if you look at while the woman is exiting the center, whether she's given the advices, the right advices, the right referrals, but also whether she's able to record and report, so that the loop goes back to the district, to the state, and then the decision making comes back through the electronic system for proper action at different levels. So this is where digital competency becomes an integral part of the overall core competency set of a provider. So we have done this mapping for more than 50 different role-based scenarios, and this was presented to the cabinet also by the last MD NHM. So similarly, we are now thinking about expanding it to cadres that have to be mapped for such competencies. Dr. Amnesty, would you like to take over, please? Thanks.
Thank you. So again, just moving from the A&M to the ASHAs, so it's a very sort of applied process of taking what the existing guidelines are, looking at the roles and activities. Highlighted in red is an example of service provision. We've carried that slide over here. You can see we similarly would map the competencies to each of these activities and then the digital competencies on top of that. We're able to sort of link back with global frameworks, hence the patchwork of colors on the right, where sort of, for example, managing digital records securely maps back to larger global frameworks on the competency area of safety. We can then take those digital competencies and get quite granular in terms of the required digital skills to attain these. So this, you can imagine, leads to sort of quite an exhaustive list of digital skills. We then have to go through a process of prioritization. You have realistically, in doing an assessment, maybe 45 minutes with a provider cadre. So this then leads to sort of a cross-checking of the digital skills with different desired target outcomes. Again, for time's sake, we won't be able to go into this. And then finally, you have a draft tool, and then ultimately this tool will get implemented initially as a cross-sectional survey in 3 districts amongst 5 different cadres in Meghalaya. It will get analyzed. We'll talk through some of the analysis and use case issues as we progress further into the interactive discussion. But just to sort of pause on the use, here we're thinking of it as sort of informing the digitalization of VHCs, which Dr. Marba will talk about, helping build health worker capacity, and then of course designing new innovations and then enhancing existing ones. So I'd like to invite my colleague, Dr. Marba, to come up and tell us about this.
Thank you so much, Dr. Amnesty, and a very good evening to each one of you. So building on what has been shared throughout by all the speakers in this evening, I think our vision in Meghalaya is to actually embed the competency at the grassroots level, especially within our village health councils. So what are these village councils in Meghalaya that we have? So the government of Meghalaya has actually notified these village health councils, or the VHCs that we called, as a nodal community institution to mobilize action on health and nutrition, and also to be able to serve as a critical bridge between the state health system and the communities. And as you've seen from the slide, that since March 2022, we have been able to form around 6,700 VHCs that has been formed across the state. So the uniqueness of the VHCs in Meghalaya is that they function within this traditional governance system, making the headman or the chief and the village councils to play a very central role in community participation, understanding power, equity in the local health governance, and thereby they were able also to discuss these health challenges with the kind of authority and power that they have within them. They're able to facilitate problem solving. They'll also be able to facilitate actions and also discuss these health challenges during these VHCs meetings that they usually have once a month. This is a structure of what the VHC is. Each VHC should have at least 10 executive members, which the uniqueness of this is that 50% of these members has to be women. And the members are all of these members, thank you, are re-elected after every 3 years. So the headman typically, as you can see from the slide, he typically serves as the chairperson of these VHCs, and this actually reflects a very strong traditional governance structure which we have under the district councils. Then we also have, how does the state have actually involved the VHCs? You can see here, when you see the arrow over there, we find that the VHCs are also involved in the state implementation of outcome-based budgeting, or the OBB. So OBB is being implemented where the funds are linked to the 3 state goals, and that is reducing maternal and infant mortality rate and improved life expectancy. OBB was implemented with the aim to build motivation in the healthcare functionaries by granting autonomy with accountability. But the intention of OBB is that planning and decision making of the healthcare functionaries would involve the VHCs, ensuring that budgeting reflects community priorities, and that is the main role of how the VHCs are being involved. So given this critical role of the VHCs, we realize that digitalization becomes very highly relevant. Our goal is not just digital reporting, but digital empowerment, just like have been said by our earlier speakers. We see that from this slide, we can see that digital competencies is actually about strengthening community representation and leadership, and as you go along, you will see that it's actually moved into the local problem solving, where the VHCs will be able to create demand generation for the healthcare. And in doing so, the VHCs will be part of this health planning and decision making, and also in monitoring and accountability, which ultimately perhaps could create ownership among the VHC in terms of improving health outcomes at the village level. So how do we envision the VHC digitalization in Meghalaya? So we see digital competency assessment as part of the larger transformation process that we are going to discuss after I finish, where my colleagues will take over. So how are we planning to do this? We are planning to actually map first the core competencies and the digital competencies of the VHCs. And after that, we actually analyze the existing app-based data that is already there to understand the functionality. And then we're also going to conduct survey to collect some of the key performance indicators, such as the percentage of members attending meetings, such as the use of digital tools in meetings, and so on and so forth. And finally, we classify these VHC based on the functionality levels. The outcome of this whole process will not just be data. It will actually enable us to co-design a performance scorecard, to be able to identify the barriers in data integration, and also create the feedback system so that this information flows back to the VHCs, thereby strengthening the leadership and thereby strengthening the ownership. Because ultimately, digitalization is not just about technology, it is about strengthening community institutions. And in Meghalaya, we hope that when digital competency is embedded within the village health councils, it has the potential to transform the grassroots health governance. Thank you so much.
Thank you so much, all our three panelists. We have had a look into the framework that Dr. Amnesty has mentioned. We've also taken a look at our health system through Dr. Nayanjit. We've looked at the competencies of our health workers and also how it percolates down to our communities and our villages. So next, after we've looked at all the competencies and all, we understand that the need of having a competency mapping. But when we look at we're doing the mapping, we need some measurements, right? We need measurements to be done, and what are the tools that need to be done, that needs to be used for measurements. These are very important, I feel, because they will be the tools that will accurately measure. We hope that they will accurately measure the competencies and the sensitivities that are there in the community, and that will be able to we might be able to take up all these issues through this mapping. So in order to understand the tools, we have other colleagues to discuss, and we hope that all of you will participate in this. And may I invite Dr. Diwakar Mohan. He is an associate professor, research professor at Johns Hopkins School of Public Health and co-director of the EDIT Consortium. And we also have with him our Dr. Osama. He's a public health researcher. And Mayank Date, he is a clinical and data scientist, Johns Hopkins School of Public Health. And along with them, we have Nishan Lang Kongla, and who is a senior consultant, of digital health in SHSRC Meghalaya, and Meban Yalam Tang. He is the KMD consultant in SHSRC. So I hand over to Dr. Divakar, sir.
Thank you, Dr. Thank you, Dr. Valerie. This is good. So this is the part that I love, kind of making the audience participate and provide the responses. I've been a professor for too long, so this is the part where I like to jog everybody and wake some people up, gently nudging them, saying, okay, we want you to be part of this process. Everybody talked about trust, right? And there's been so much said about the why and what of competency measurement and what do we measure. We're going to look under the hood and see how we go about this process. It's going to be a very, very quick session, especially because we have limited time. In reality, we do this over many months and if not years. In this instance, we want to kind of provide you with a very brief snapshot of how we go about this process. So, on this right-hand side, you see this Mentimeter QR code. Hopefully, everybody's pointed out. It's also on the back of these. Yeah, and all the questions are within the booklet as well, pamphlet as well. So, we actually, when we first tested some of our tools, we had a really long list of digital competencies and skills that were mapped to them to test. So one of the first key questions that we needed to address was, how do respondents understand what you're asking of them, right? So this is very important because people can have a variety of ways in which they can misunderstand you, right? Okay, good. People have started coming in with these are some of your colleagues' responses. Feel free to add on to them. If you feel that some of this is true, please vote on it. It'll probably push it up in size. Okay, cognitive testing. Looks like something's coming up that seems to be quite popular. There's so much out here that we take for granted. It is very intuitive to us in parlance that we need to make it simpler. We need to explain it in a way that people will understand. But the process that we need to make sure to undergo this, we do this, what we call cognitive testing. And within your pamphlets, we have provided some material about how we've gone about this process. And our colleague, Osama, will give you a very brief snapshot of how we go about testing some of these questions.
Yes, so as Divakar rightly pointed out, so we have been doing this cognitive testing in India, Nigeria, and Kenya as well. So cognitive testing is basically a qualitative research methodology where we take like a set of survey questions and then we test it in terms of understanding the local worldview or the misinterpretation of the questions. And we test it like a series of rounds and it's a iterative process. And by end of it, we again use this for the pilot testing. So how it is different from pilot testing is that pilot testing is basically looking at into how the survey is implemented, and whereas this looks into whether the questions is actually capturing the intended response. Next question. So, you know, once we have cognitively tested our questions, how do we ask them? So, what approaches do you think, when it comes to especially testing digital skills, what approaches do you think are most effective? So we have some options like, you know, self-reported, observed skills, both. So I can see both is currently the popular choice. Just wait to see where the chips fall. Okay, so it seems both is currently the popular choice, with the next best being observing the skills. Okay. Yeah. So in the same vein, do you think, so since a lot of people did say, you know, observing skills, do you think people will over-report their ability to perform digital skills? Oh, wow, even split. Okay, yeah, yeah. So people, the popular choice currently is people will always over-respond. it's close. Depends on the situation. All right. So this was actually a data where we ran a survey on digital skills in one of the states in India. And what we see is even between men and women, while there is disparity by gender, people do not over-report their skills as much as we thought. In fact, in some cases, they under-report certain skills. And when we asked them to perform them, they were able to do those skills, even if they hadn't previously reported being able to do them. So I think that is an important consideration.
So the next question is talks about the ASHAs, and just to contextualize the question is, the typical ASHA profile in Meghalaya is someone, a woman who's in her late 20s or early 40s, often married and then constricted with family responsibilities and also managing the health work. So to kind of really assist in their daily activities as an ASHA, what do you think, if we want to actually measure their competency in terms of their digital competency, and how we kind of anticipate what challenges they may face when you're trying to measure a particular competence through a survey, considering that the fact that their work realities is that they're burdened with a lot of workload across different programs, having to travel long distances in difficult terrain, and also being a trusted community mobilizer. Their work is really embedded in actually building trust in the community, in sensitizing families, tracking beneficiaries, and also connecting people to services. We feel that getting the assessing the digital competency is something that's really important. So also having an understanding of what the challenges might be to actually gauge that assessment is also important. And as we see here, there's a lot of responses in workload, time, digital competency, low literacy, motivation. That's also, thank you.
So this is a very brief snapshot from a survey which showed what were the key difficulties that ASHAs or frontline workers may have in fulfilling some of these self-administered surveys. So as you can see, literacy seems to be quite a challenge. In fact, only about one-third could actually own the phone, and then even when they had a phone, some of them could not even make an outbound call. So these were some of the challenges that one is most likely to face when having self-administered surveys in this kind of a setting.
So, yeah, once you have the data, how do you think, would that data be presented? What do you think could you do with that data? Especially on skills, do you think it's most important to use them as a composite index, or to look at individual skills as, units of measurement? Okay. So, grouping skills by competency domains. Great. So that seems to be the winning choice. So there's no right answer to this. You can do both ways. So this is these are the competency domains that were present in DishCom 3.0, and you can group. You can aggregate the level of skills at a population level to report on SDG indicators, or you can also create scores based on individual skills to understand your target demographic.
Yeah, so now, as Mayang was saying, now that we've mapped up all the digital skills from different competencies, right? So it's nice to sort of think about how do we use this data, right, to benefit our health workers. So maybe better monitoring and evaluation, better resource allocation and things like that. So it'd be nice to think about it. Yeah, data analytics, better digital infrastructure. Targeted training is a good one. After we've seen this data, we'd know better which category needs specific skills and competencies, right? Yeah, we would definitely learn the challenges from the data that we've taken. Yeah, so basically a lot of capacity building and things like that. So yeah, I'd hand it over to Dr.
So we did learn some very key messages from this, that we have to tailor some of our measurement techniques to the context and to the person that who we are planning to measure. It is also very important to tailor some of these to the questions that we want answered. And I want to give the last few minutes to Dr. Arappa to kind of provide us key takeaways from our session today.
Thank you so much for this opportunity. I won't summarize and bore you, but I'll tell you why the World Health Organization is extremely delighted to partner on this effort. As World Health Organization, we're essentially focused on building foundations for digital health and AI. And one of the key foundations that you need is building digital health competencies for all healthcare workers. And very often when we build digital health competencies, people typically start from the top. And I've been one such beneficiary. I work for the government of India, I work in WHO, I've been trained both in digital health and AI and did my PhD in computer science, although I'm a medical doctor. So very often globally, when you talk of digital health competencies, they've typically started from the top of the pyramid, that is physicians, nurses, and we've started from frontline workers. So I'm actually delighted that the World Health Organization is partnering with the government of Meghalaya in actually building from the bottommost as the frontline workers. Because very often studies suggest that frontline workers today have to remember close to 90 to 120 passwords for the variety of digital tools that we've been implementing at the field level. So without any competencies, without the fact that they don't have digital skills, we assume that they'd be able to do a job of a lot of people. And more specifically in India, when you think about ASHA, these are really not even functionaries of the government. These are voluntary activists. These are volunteers who provide a lot of healthcare, a predominant healthcare to the most disadvantaged and underprivileged. So I'm very delighted that the Gates Foundation is actually supporting this effort. I have also colleagues from the World Bank, other donor agencies, and as a technical agency at the World Health Organization, both from the regional office and from with our colleagues in the country office. We're extremely delighted to partner, and we would really want to ensure that this is a movement which starts in Meghalaya but sweeps over the rest of the country and the region, because I work for countries apart from India as well. So want to thank the team from the University of Cape Town, John Hopkins, and the leadership of the government of Meghalaya, and we really look forward to ensuring that we not only assess, evaluate, and then implement eventually, and implement not just in one state, but multiple states across. And thank you all so much for coming to a session here. Very often participants are more excited about more shiny, glamorous tools, but this is a very foundational work, and we've just laid down the foundations for AI in healthcare use by setting the foundational document, the strategy for AI in healthcare in India. We just got launched about an hour back. And one of the key pillars in the strategy is on workforce capacity building and change management. And here is a state government which is already leading the light in thinking very broadly about this. So thank you for the leadership of Sampath sir and colleagues. And thank you everyone for being here. Thank you so much.
I think, well, before I think to end the session, I would like to thank everybody. I hope you enjoyed this participatory work. Like, you know, the entire team has contributed to the session. So just like I wanted to, my final things, I was just thinking, you know, when, you know, I'm also like you're a medical doctor and turned into computer science, like the other way around now. I studied engineering, then PhD in public health. Okay. So what I would like to say is that there is when the computers were introduced in India, I think there was a tremendous challenge, and it took a lot of time, you know, for you know, to really take that. Very recently, we are using e-office, electronic office. Very recently, not, in fact, it has not come to all the states. Slowly, we are doing it. Imagine, so the delay, the lag time, that because we have not invested in building the competencies at the right level. So I think it's a very fundamentally very important, as Dr. Karthik said, to start from bottom up. You know, when you talk about AI, You also start talking about a bottom-up movement. This is a bottom-up movement to really build that, the competencies and the motivation. Competencies actually gives motivation, public service motivation. So we really need to bring a mission bureaucracy or mission government, system that actually over a period of time. So that's the kind of idea, and this will be super helpful for the states to get the return on investment. What is the return on investment on the human resources? Because every state spends almost like 50% of their budgets on the human resources, salaries and pensions. And if you really build these competencies, imagine how the state would deliver in terms of the expectations of the people and the outcome. So that's, I think, with this, thank you everyone for participating and listening to this exercise, and we welcome you to be part of this entire journey that what we have been actually trying to do. Thank you.